I'm Dr. Jacqueline Chassie, Vice President of Medical Education at Emerson, and I'm really honored to be able to have some time to sit down with Dr. Mimi Guarneri. So Dr. Guarneri, thanks so much for joining us.
I'm thrilled to be here. Thank you.
So before we dive in, can you tell us a little bit about your background and also why you jumped into integrative medicine?
Oh, that's a little bit of a story. I started as an interventional cardiologist, so I spent many years of my life putting in coronary stents and doing angioplasty. And this is great work in the acute setting when someone needs it. Around 1996, I kid you not, I walked out of the cath lab and Dean Ornish was on the other side of the door. And he said to me, I need you to study something for me. And I thought for sure I didn't know who he was, so I thought he had a balloon catheter or an angioplasty balloon or some combination of things. And he said, no, I want you to study my lifestyle change program, yoga and meditation, and vegetarian diet, group support. And I said, whoa, wait, you got the wrong person. Well, fast forward, I ended up doing all that research. And while I did the research, I also went through the program myself because they were very sick heart patients, people who couldn't have angioplasty, people who were not candidates for bypass. So I was always there when the patients were exercising and in their yoga class. And I began to change my own life. I went in 1 week from a meat eater to a vegetarian, and I watched my cholesterol go from 320 to 120, and I started to do yoga and meditation. I mean, it was life-changing for me as a clinician, and I thought, my God, why didn't I learn this in medical school? And then I was watching the patients in the program, and they were losing weight. They were laughing more, their relationships were better, they formed these bonds, and it just sent me on this journey to say what else is out there that I didn't learn in medical school. And that's the journey I've been on ever since. I've learned everything from healing touch to how to use nutraceutical therapies to really focusing a lot on nutrition and mind-body therapies, all things I never learned when I did my cardiology training. So I'm in constant learning process.
That's fascinating. Now, did you have a skepticism when you first stepped into exploring this new area?
I'm the biggest skeptic in the world, but I guess what I'm a little different at is I don't shut the door. So I say, I'm willing to listen, and I'm willing to try. So a lot of things I tried on myself first. And they say when you're ready, the teacher appears. And one of the heart patients had herpes, and I had never been exposed to herpes. And I ended up with disseminated herpes infection. I was so sick, I missed work for a week, tonsils out to here, and our nurse at the time, Ronnie King, was also a healing touch practitioner. So here's an ICU nurse who's doing this thing that I never heard of called healing touch. She said, let me work on you. And I kid you not, she did a healing touch treatment. I got up, I got dressed, and I thought, oh my God, what is this, right? I have to learn it and I have to bring it to my patients. And I had a very similar experience with acupuncture. So it seems like I had to learn the hard way. But it opened the door for me to say, okay, let me understand it, let me see if it makes sense, and can it be of service to my patients.
I love that. And it can be really difficult when you have a skepticism to keep the door open, because we live in our little box of our own worldview. So
right, and in the medical world, you're always so worried, what are my colleagues going to think? Like people would say to me, what are your colleagues going to think that you're teaching yoga and meditation? I said, yeah, and exercise and teaching people to eat. Like that was a bad thing.
Those wild ideas like eating healthy.
Exactly, it was considered alternative medicine. I said, this is not alternative medicine, And of course, things have changed now, but that's how it was, even in the 90s.
Yeah. Thankfully, things have shifted, although not completely.
Not completely.
It is funny because you talk about what peers do, but when they poll physicians, it's like more than 75% who use supplements on themselves, but very few recommend it to patients. It's like very secretive still.
But they're also not trained in it.
They're not.
You have to remember, clinicians, when they're not trained in something, when you go to medical school, you come out believing you have to know everything, right? And then you have to have a certain level of ego, if you might, because you're treating people, you're taking care of lives, right? And so when something comes in their space that they know nothing about, their first reaction is, oh no, that can't be good. I don't know about it. I didn't learn about it in medical school.
Yeah.
Right?
It's a healthy skepticism.
Yes, but it builds walls. So it's okay to say I don't know about it, but at the same time we have to say, okay, let me learn, let me get educated, where might it fit in, and so on.
Yeah, great. Well, thank you for sharing a little bit about your story.
Thank you.
So I really would love to talk today about cardiovascular disease, your area of specialty, but specifically for women, because men and women are not exactly the same. Of course, women have a hormonal component to integrate, particularly when cardiovascular disease starts to hit. It's in peri and postmenopausal women when those symptoms really become something that need management. So can you start by telling me a little bit about how you think about cardiovascular health in women, and especially maybe the areas where you think that things need to be different from how we talk to men?
Well, women, first of all, are the caregivers of the world, and they take care of themselves last. And most women think having their pap smear and their mammogram, oh, I did everything I need to do for my health, forgetting that cardiovascular disease is the #1 cause of morbidity and mortality for women, right? Clinically, I actually, the biggest things where I think women differ from men, it may be in presentation, right? And women may just come in and say, I feel fatigued, or I'm combing my hair and I notice a heaviness in my arms, or I have a discomfort in the shoulder blades. They may not present with the classic, oh, I go up a hill and I get chest tightness, chest pressure. Of course they can have that, and I have many women who have that. So I think we need to listen and not judge the book by its cover. I have had 36-year-old women have stents.
Wow.
Right? And so if you're looking at a young woman and you're in the emergency room, the first thing you're thinking, if you have tunnel vision, oh, she can't have heart disease, right? And frequently women are sent out, oh, maybe it's your gallbladder or your GI tract. And so again, my message to clinicians is always to listen to the story. If you listen to the story, the patient will almost always give you the diagnosis, right? So really listening to the story and knowing that women may present differently than men. And you mentioned menopause and perimenopause. This is really an important time because we have a lot of vasomotor changes going on. And this is a time when we see women having more arrhythmia. This is a time when women start to put on weight and develop more cardiovascular risk. This is a time when women are more prone to dissection of blood vessels. Women may present more with small vessel disease causing chest discomfort. So lots of things to be on the outlook for.
Yeah. What are the key drivers or lifestyle factors? So let's talk about how you build a protocol. And I think for the sake of today, really focusing on a patient that you might be doing more prevention or more wellness orientation, maybe a woman who has a higher risk for cardiovascular disease or showing some early signs. What are some of the things that you really start with from a lifestyle perspective with a female patient in that situation?
Well, the first thing I like to know is what exactly is the risk and how far have things progressed. So I do want some data, and that can be on a blood test side, of course, inflammatory markers, hsCRP, LPPLA2, MPO, TMAO, fibrinogen, uric acid, homocysteine, LP(a). I want to know some lipid markers, right? I want to know what the HDLP is, LDLP, and I want to know ApoB, A1, and then of course I want to know markers like fasting blood sugar. Does someone have high fasting insulin? What is the hemoglobin A1C? So I need some information because that's going to help me target how do I personalize decreasing risk. I usually will do a Nutri-Eval because I really like to personalize my nutraceuticals. So, and I am shocked when I get the Nutri-Eval results back because people are profoundly deficient in B vitamins, in antioxidants. The Nutri-Eval also gives me information about whether or not someone has dysbiosis. Maybe I'm dealing with yeast. Also heavy metals. Perhaps this is someone we're going to end up needing a chelation protocol on. So it really gives me some insight into what direction I have to go. And then if someone has a lot of stress in their life, or they've been through a lot of stress, and now they're telling me, gee, I feel fatigued, I'm probably going to look at an ASI, an adrenal stress index, because the 24-hour cortisol, again, is going to help me personalize. You know, if their cortisol's low in the morning, I'm thinking about using adaptogens and licorice extract, and you know, and maybe if it's high, I may be thinking about ashwagandha, you know, and calming adaptogens. So getting this information is important, and then for me, and then from a cardiovascular, and I'll also do a food sensitivity. So depending on what I find in the interview with the individual, obviously somebody with a lot of GI symptoms, even if they're there for cardiovascular health, we have to fix the gut, right? So I may get a 3-day stool, I may do food sensitivity testing. And then, of course, the easy testing to do is a carotid IMT. What is, you know, simple ultrasound and measurement of the thickness of the carotid artery. Very easy to do a femoral artery ultrasound, an aortic ultrasound, looking for plaque. And, you know, femoral artery ultrasound is sort of the new boy on the block because it predicts risk. And then a coronary calcium score may be in order, especially for those people that need a little, you know, picture's worth 1,000 words to get motivated. And then I will, when I have, and an endopat, because the endopat will tell me what the endothelial function is looking like. And if someone has a good RHI, above 2, that's great. And if it's not, hopefully when I correct the micronutrient deficiencies, I'm going to improve that.
Improve the health
change the diet, improve the health of the endothelium. So having that data really is what helps me to personalize a protocol for someone.
It's interesting because I wonder, you know, do you get pushback from patients when, for example, you're suggesting a gut workup when they come in with cardiovascular health? I mean, it is something where it's such a major factor for inflammation.
Well, they always ask. They say, "What? You're the heart specialist. Why do you care about my gut? Why do you care about
you're one person.
Why do you care about my heartburn? Why do you care about my gas and bloating?" And it's because vascular disease, we now know, is an inflammatory disease. It's associated with oxidative stress, immune dysfunction. We know this, and the gut is a potent source of inflammation. The foods you eat could be a potent source of inflammation. Food sensitivities could cause inflammation. Heavy metals can cause inflammation. And then they start to understand, you know, oh, okay. And an easy way for a lot of patients to understand, especially women, when they come in with bone densities that show they have osteoporosis, and if their gut isn't right, I said, well, if your gut is not working right, how are you going to absorb all of the nutrients you need to prevent osteoporosis? And that's an easy way where people can say, oh, okay, I understand.
Cardiovascular medicine does seem to be an area of medicine that has been a little bit more almost isolated when it comes to patients who are pursuing care. Even PCPs, if patients hit a high risk level, they refer to a cardiologist. In my experience, because you know my family has a lot of cardiovascular disease, is that it does get very segmented. So I love that you're pulling it back to the whole person. And I'm sure that's unfamiliar to a lot of patients, but probably they walk away feeling really grateful for that.
Well, and they come because they know they're going to get something different. And also, we have to remember, and you're right, because when the primary care docs, which are spending a lot of time training, right, on evidence-based use of nutraceuticals, training on mind-body therapies, global healing techniques, and so on. And then they get a really sick patient that goes to a cardiologist who says, oh yeah, forget all of that, just take these 5 drugs. And that happens.
Yeah.
I used to have it happen with my patients where they'd go back to their primary care doctor and they say, oh, you're not going to fix your diabetes, just take all this medicine.
Right.
And the patients would come back and tell me, and I say, no. I said, why don't we do this work together, and then you can be a model for them.
Yeah, you can prove it wrong and get them to open the door and maybe consider that there are other things that can work. So let's shift and talk a little bit about supplementation when it comes to cardiovascular health. What are the key nutrients or botanicals even that you look to, that you're using a lot for women who are, really wanting to proactively support their cardiovascular health?
Right, so again, I may tailor supplements to the NutriVal.
Of course.
So for example, if I find someone needs antioxidants, I will give them appropriate alpha lipoic acid, vitamin C, mixed tocopherols, whatever it is that it looks like they need.
Mm-hmm.
I will dip their urine in the office, and if I see a lot of sulfates in the urine, I will presume they have a CBS SNP that's revved up,
mm-hmm.
and so I'll support the sulfate pathway with molybdenum, manganese, vitamin B6. Again, I'm trying to target to what people need. If I identify that they have MTHFR, whether it's a C677T or 1298, I might use a methyl form of folate,
mm-hmm.
providing they don't have a COMP mutation. So I'm trying again to tailor to what they need. But if I had to pick a broad way of thinking about it, let's say I have to lower LDL. Let's say my goal with you is to lower LDL.
Mm-hmm.
Well, certainly I'm going to put you on a high fiber diet, and I'm going to take you off the saturated. I don't let my patients eat saturated dairy and meat
mm-hmm.
products if my goal is to get the LDL down. But I may then reach for, red yeast rice. Mm-hmm. I may reach for plant sterols. I may reach for niacin, which would give us a LDL reduction of 11%, but that's not usually my go-to for just LDL. So I'll if somebody has high triglycerides, low HDL, then I'll probably reach for niacin. Mm-hmm. I mean, to me, there's no better nutraceutical for high triglycerides, low HDL, and small dense LDL particles and LDLP than niacin, mm-hmm. right? I'm still a niacin believer, and it works when mm-hmm. it's done correctly. So again, targeting what do people need. If the omega check is low, I'll give EPA. I want to push that, EPA, DPA, DHA system. So I'll give vitamin D. I keep my vitamin D levels 55 to about 75. And I think we do have good data to support, especially for prevention.
Okay.
Of breast cancer, higher levels than what's currently being recommended by the Institute
mm-hmm.
of Medicine. So that's sort of how I do it. I look at what is it that, omega-3s will drive down triglycerides, fiber will drive down cholesterol and blood sugar, berberine will drive down cholesterol and blood sugar, mm-hmm. Bergamot will drive down small particles in many patients, raise HDL in some mm-hmm. patients, lower LDL. So we have we have quite an armamentarium of good stuff that we can use.
Yeah, great. Well, thank you so much for spending some time with me today and for sharing your amazing wisdom with our watchers today. So thanks so much.
Thank you so much.